Our recent cover story in CardioSource WorldNews Interventions reviewed the work being done in advancing percutaneous options for patients with valvular disease. Now, TAVI rules the school, but there's actually a lot happening elsewhere. For example, we're here to talk about one-year outcomes from the early feasibility study of the Harmony Transcatheter Pulmonary valve. And to do this, I'm with Dr. Lee Benson, who is an MD and professor in the Department of Pediatrics at the University of Toronto and director of the Cardiac Diagnostic and Interventional Unit at the Hospital for Sick Children in Toronto. Now, in our cover story, by the way, you'll find it interesting. Deborah Beck, our writer for that one, noted that if TAVR is the prom king, then transcatheter mitral valve intervention is its good-looking best friend, while the percutaneous pulmonary valve has kind of been a wallflower until now. Are we about to see this move so it's no longer a wallflower?
Well, a lot of it has to do with the patient population and the number of patients. Patients with congenital heart disease, it's a boutique subspecialty because when you compare it to the number of adults with coronary artery disease or valvular disease, we pale in comparison in terms of numbers. But it's nice to remember that the first percutaneous valve implant in a human being was in a pulmonary valve done in the year 2000 in England.
I had forgotten that, so it's really nice to be reminded of that particular fact. So now where are we?
Well, the population of patients where that valve design was used was very unique in a very small population of patients who've had surgical correction of congenital heart lesions. Technically, they had a conduit or a tube sewn in from their right ventricle to their lung arteries, and that tube over the course of time can become dysfunctional, stenotic, and regurgitant, and the Melody valve, which was specifically designed for this application, addresses that kind of issue. It's limited by the diameter of the conduit. So the Melody valve can go up to about 22 millimeters internal dimension. Other valves have been used as well, such as the Sapien valve, which can go up slightly larger. But it's still within the conduit itself. But the vast majority of patients who undergo corrective surgery for congenital heart lesions, particularly involving the right side, undergo a surgical correction, which is what the surgeons call a transannular patch. So they actually cut across the valve annulus to enlarge it and patch across it. This is usually done in the child's about 3 or 4 months of age, sometimes even as a neonate. But when they become much older, the ravages of pulmonary insufficiency cause the right ventricle to dilate, ventricular dysfunction, arrhythmias, and there is an incidence of sudden death. So technologies to implant a valve have become very important, and up until recently, particularly with the Harmony experience, surgical valve implantation was the only method of implantation or correction or strategy that was available. So this particular valve was designed specifically to address this potulous, large right ventricular outflow tract anatomy, so that we can address the issues of pulmonary insufficiency.
And it's actually taking the technology of the Melody and kind of moving it along, and it's kind of grown from that, correct?
In a way. I mean, it's a very different approach. The Melody is a balloon expandable stent, and this is a self-expanding stent. The valve is the same dimension, it's 22 millimeters in diameter. So it's a slightly different kind of implantation because the environment is very different.
Right. So talk about the Harmony early feasibility study.
Yes, well, it was three centers. One was Sick Kids in Toronto, nationwide in Columbus, and Boston Children's. And we got together with Medtronic, who designed the implant, to look at the feasibility, safety, efficacy, but most importantly, what happens to the valve when it's implanted. And it turns out that the right ventricular outflow tract, or the connection between the right ventricle and the pulmonary arteries, is not just a passive conduit, but it's a very dynamic environment, and there's a lot of stresses and strains which go on during the cardiac cycle. So it's imperative that if you're implanting some kind of a device inside this area, that you have a good idea of what the stresses are on the materials, the fatigue of the materials. So that was the primary goal of the study. It was really an engineering study. Do the implant and re-image the implant around 48, 72 hours with CT scanning to see what kinds of activity was going on. And of course, we were most interested to make sure that the valve was competent, non-stenotic, there was no paravalvular leak, it was safe to implant or technically straightforward to implant. And as it's turned out, it's been, in the vast majority of implants, I think it's 18 of 20 implants, it functioned exactly the way we had in our mind's eye, which is very unusual in medicine, that something actually works the way you think it's going to work. And it was very, very impressive. Now, the one thing we did learn is that the geometry of the right ventricular outflow tract is so varied that one size will not fit all. And we definitely need other sizes, although the shape is the same, other sizes to implant because of the diameter of the outflow tract.
So sizes and everything, but having available sizes
Yes.
really can make a difference in interventional cardiology.
Well, in this particular case, it can.
Okay, in terms of follow-up, you've got what, 1 year follow-up data is what you were presenting here.
Yes.
And did everything look good?
Everything looks good. That's right.
And the FDA seemed to be happy.
They're thrilled. Hard to believe.
So you have a pivotal IDE study. What is this all going to mean for patients, do you think?
Well,
if everything turns out positive.
Well, the melody valve application in conduits, I'd call it a lost leader in a way because the population is so small.
Right.
But the population of patients who have tetralogy or flow repair, these transannular patch surgical procedures, it could be 4 or 5, 6 times the number of patients. And that's the way that the surgeons repair this lesion. All these patients are going to have the ravages of pulmonary insufficiency over the course of their lifetime. So it's, in many ways, this is a game changer in terms of the way we can care for this adult population or older population, young adolescents and older, who require a pulmonary valve implant.
Now, you also were presenting here this afternoon on pulmonary artery stenting during TPV replacement.
Yes.
What's that all about?
Not infrequently, patients who have these kinds of problems have stenosis of their pulmonary arteries. And the stenoses can be very central and involve one branch or both branches, or it can involve the connection between the chamber and the lungs. Well, if you have a stenotic area, it makes implanting a percutaneous valve very, very complicated. And there are a number of techniques that have been developed by other investigators to ways to implant bare metal stents or covered stents in the right ventricular outflow tract in the areas of stenosis, so you can enlarge the vessels and then get a landing zone for the pulmonary valve.
What's exciting is in that same session, they talk about the pulmonary valve pipeline. The fact that there is a pulmonary valve pipeline is, I think, encouraging. Are you encouraged as you look ahead the next, say, 2, 3, 5 years?
Well, as I come to this meeting, I find that it's a bit like science fiction really here. And I think that there are a number of initiatives that ultimately are going to improve the care of not only the adult with acquired disease, but many things that are coming down the pike for patients with congenital heart disease.
Well, there's now going to be a new journal in that area too, which I understand from this meeting, which is kind of nice. So thank you very much for your time. And please check out the transcatheter valve cover story that Deborah Beck wrote for us for CardioSource World News and CardioSource World News Interventions. I'm Executive Editor Rick McGuire.